Good afternoon. Welcome to the kickoff event of the AI for Oncology Lab, which is a collaboration between the Netherlands Cancer Institute and the University of Amsterdam. We are Clarissa Sanchez, Scientific Director from the UVA, Jonas Theeuwen, Lab Manager, and myself, Jan-Jacob Sonke, Scientific Director from the NKI. In the AI for Oncology Lab, oncological and AI expertise are merged, and the goal of the collaboration is to improve cancer treatment through innovative approaches in artificial intelligence. We deal about cancer, and cancer is still a terrible disease, causing worldwide about 10 million deaths as counted in 2020, last year. In the Netherlands alone, it's about 120,000 people that were diagnosed with cancer and about 45,000 cancer patients that died. Fortunately, over the last 30 years or so, the 5-year survival rate increased by about 30% point, from 35 to 65%. And this is the result of fundamental and translational research, advances in screening, early detection, minimal invasive interventions, and personalized therapy. And we believe that modern AI technology can help to further improve cancer treatment.
AI is a disruptive technology, quickly transitioning from a future innovation to surrounding us in our daily life. From driving cars to fighting inequalities in the cities, there is no field that hasn't embraced AI technology. In healthcare, AI technologies have shown unprecedented performance, reaching human performance and even surpassing it in specific tasks. Its potential has been shown to be very positive in screening of diagnosis and treatment planning and treatment decisions, and even prognosis and prediction, permeating in clinical tasks previously reserved for human intelligence. However, the adoption of AI in healthcare is still at its infancy. In the AI for Oncology Lab, we seek to realize AI breakthrough in the fight against cancer. Supported by the AI Technology for People, the National Innovation Council for Artificial Intelligence, ICAI, aims at enabling the potential of AI to create economic growth in diverse areas. With a focus on developing AI knowledge and talents, ICAI Lab, like this one, the AI for Oncology Lab, move forward the field by fully harnessing the potential of AI and successfully managing its social consequences.
To celebrate the opening of our ICAI Lab, we have created this event to explain our plans for the next few years. But before we explain our exciting plans, we have two excellent keynote speakers, Dr. Mann and Professor Hahn, who will tell us about the potential and the implications of artificial intelligence in oncology. At the end of the event, there will be an official opening with champagne. But first, we have some words of welcome by Marien van der Meer, who is member of the Board of Directors and Chief Financial and Operational Officer at the Netherlands Cancer Institute.
I welcome you at the launch of the AI for Oncology Lab. The lab functions at the interface of oncology and AI. I am convinced that it will make a significant contribution to achieve our mission to get a cure for every cancer in the future. I thank the University of Amsterdam for the good cooperation. I wish you all the success, and I'm looking forward to see your great results in the future.
Our first keynote is Professor Horsehand. He's director of the Fraunhofer Institute for Digital Medicine and professor for medical imaging at Jacobs University Bremen. His work addresses the digital transformation of medicine on the basis of multidisciplinary data integration and the modern machine learning methods. There is not enough time to say all the accomplishments that Horst achieved in the last years. I met him when I worked in the Radboud UMC. Together with, he participated in different European grants, like Haman and Vitseman, dedicated on improving breast cancer diagnosis and therapy. In the last year, I had the wonderful opportunity to work closely with him in a collaborative project for automation of medical imaging, where he passed on his consistent focus on increasing efficiency, quality, and safety of diagnostic and therapeutic processes in oncology through AI. Horst, it is my pleasure to give you the word.
Thank you, Clarissa. Dear colleagues, it's a great pleasure and honor to speak here for you and in front of you about a small story that I'd like to share with you. So I call it the future of AI in oncology, but I could equally call it the story of medical complexity. This is our mission statement here at our center. We try to make a contribution to resolving the rapidly increasing complexity. And we believe this is only the beginning. And already today, we are at a point that even specialists cannot have in their mind all the latest research results fully precisely and apply them within minutes to the current case at question. So we believe computers can be of great help. And I just want to tell you my view on this. Let me look a bit to the world, what other people have said and done. So what you might be aware of is this meeting in Boston that is a yearly event called the World Medical Innovation Forum. I found the format quite interesting because they managed to invite people from around the globe and to discuss for different topics, what are the 12, for every year, 12 disruptive innovations in a given field. And so in 16, they discussed about cancer, of course, which is the major topic. And then on cardiovascular disease. And already 2 years later, in 18, they just framed the whole meeting around artificial intelligence because they felt this is probably the most disruptive technology that will accompany us, that will help us. And there's a statement that I brought here that they said is Star Wars technology. That's what we currently have available, but in a Flintstones healthcare system. So we believe there's a lot that will be changing over time. And I want to address a few thoughts about that. So then a year later, they named the most prominent disruptive innovation for year 2019, reimagination, so reinvention of medical imaging. For me, that was unexpected. So that's my field of origin. And yeah, they say now where AI and these complex information sources come together, we will have a totally new possibility of insight into diseases and predictive patterns. And then, not surprisingly, in 2020, they framed the whole meeting around COVID-19. I would also like to share a word on COVID-19 later. But another quote here from Kevin Kelly, who talked about our society as a whole. And he said, no, this is not what could happen, but he said this is what will happen. The inevitable in his book. It's a nice reading. And one statement from him I wanted to bring to you. He said, we are morphing so fast that our ability to invent new things outpaces the rate we can civilize them. And I think this is totally true in medicine as well. We have now so many options, so many new therapeutic approaches, and also diagnostic tools, and now even methodological tools, computational tools, that we cannot validate them sufficiently with our old methods of evidence-based medicine. This is just too slow, and there's too many options. So I have another slide for you on this, what I call the diagnostic dilemma. All medical areas are heading in a direction, at least to my perception, please tell me if I'm wrong, to be more interdisciplinary than before, individualized, participative, and predictive. That's where we want to go. And always at highest quality. So quality levels must increase, error rates must decrease, but the cost pressure is always on the system, as before. So patient groups get smaller and smaller by these great advances in biomedical knowledge. We even call this orphanization phenomenon, where patient groups are just so small that they qualify for a rare disease, even if it's a type, for example, of lung cancer. So we create also complexity, which is a source of error by itself, because medicine must always simplify. We must have very simple rules, easy to apply rules. Otherwise, medicine would be too error prone. So this human simplification is in a way in a strong contrast to this dramatic increase of complexity. And now my hypothesis is that AI and computer support is a needed tool to solve this problem, to advance further medicine. And here's another statement from Christian Dirks, who I know well and have worked with him. He's a doctor, a medical doctor, and a lawyer. And he has his offices in Berlin. And he said already today, in his view, data is the most important raw material in medicine. But similar to Kelly, we have too few certification bodies to keep up with a multitude of new applications being developed. And soon it will be just normal to apply AI, or even a mistake not to apply it. So I think the biggest misunderstanding like 5 years ago was that AI could replace humans. That's not at all the right question. AI can address our human limits. Yes, that's true. It can help us as a tool. And there's a few things that humans are really not particularly good at. For example, quantification. That's what humans often do in medicine. Radiologists or pathologists have to quantify and generate ratios, percentages, and the like. And if we look at reproducibility, it turns out that we are not super good at that, but we just do it because it's needed. And the same is true for assessing change in a bit complex scenes. So like a computed tomography scan of the thorax abdomen. It's quite a challenging task for radiologists, and they are trained for that, to, within a couple of minutes, find all relevant changes on all slices. And now the third one is even more challenging. If we have multiple criteria, multiple parameters that we can measure, and want to draw a decision by combining all of these in detail, then humans are limited, that's what literature says, to 3 or 4 dimensions of independent parameters. If we have a 5th or 6th or even 10 or 20 or 100 parameters, we need to group, we need to project on a subspace. And then we can learn rules again with our brain. And of course, computers are not limited in these directions. So there's a complementarity. There's now a new tool called AI, or practically it's deep learning, and it can help us. And so the first things, of course, is to do very simple stuff. So like segmenting a liver. So I just added this slide to show you how a computer learns by a few cases, now here 10 or 15 livers. Of course, the displayed 2 cases are not part of the training set. That's an independent test cases. And then you see after the computer has seen already like 50 cases, well, it's pretty stable. The 3D view is not changing too much anymore. And this is even more astonishing because the computer in this simple network, a neural network, only sees like a small fraction of a single slice. And that's why you have these like sheet-like flickering effects initially, because we are a bit unfair to the computer. We don't show him the full 3D volume, but only at a time, a single small window out of an actual slice. And so on the right side, you see even a post-surgical case that the computer has never seen before. And after like 100 normal other cases, computer is pretty much able to say where the liver is. Well, this is not very useful, right? Unless you want to know the liver volume or want to visualize it. But of course, the next step is then, once the computer has found the liver, it can find liver tumors. So it's just the same procedure. It sees standard units, convolutional neural network architectures. There's quite a variety of this sort, but it's all deep learning. And then, yeah, once you have found the liver, you can find abnormalities within the liver tissue. And then as a next step, you might say, whoa, let me try to find patterns which are predictive as a third step. And the questions that you can ask to these data are not limited. So we don't look only at radiological data, but of course also at pathological data. And so we must look at clinical data, at the risk models, and medication and outcome, and genetics, and integrate these different sources of information to have the best precision in our therapy. And so I want to have a few words on digital pathology. And I also had the great honor to work with people from Nijmegen here, amongst others. And because there's a very strong group in the Netherlands, or multiple sites in the Netherlands, who deal with these challenges. That's huge data sets. And we believe that the information potential in digital pathology is not at all leveraged by the human judgment of the data. The human judgment is very important, but can be complemented by computer judgment or computer quantification, classification. And there have been multiple tools how to make the computer better explain what it has found. Like here, an ADH case, and then the computer can say, well, yeah, I saw strong rigid architecture, I saw very high stromal density and the like. And based on all of my data set, I could say by confidence of 84%, I would say this is ADH. Well, this is just an example, but this is where the story will lead us to computers who can tell us more just than saying, well, this is A or this is B, and this is what we have to ask for. And it gets complex because we have multiple stainings, we can combine them, and AI is just one tool set. We have image registration, so we can very precisely overlay two serial sections which are stained with different stainings, immunohistochemical stainings, can quantify patterns on each of those and can bring them together in a joint anatomical representation. And from the joint pattern space, we can try to derive new predictive information. And so we did this, for example, on a data set together with our partners, where we looked in very much detail which relative configurations of immune cells and cancer cells, which spatial configurations and density relations are predictive to therapy response, therapy success. And I believe AI will just be very helpful to lead us through this huge complexity of information. So I now want to go on another level in the last minutes. If we really want to see AI as a great helper, we need to work together within the clinics, as I said before, but also across clinics and across nations. And so I just take for a minute the example of COVID-19. We had a collaboration together with Amsterdam and Nijmegen, and together we just tried to find out what is the best set of tools and algorithms that we can use to apply in the COVID-19 imaging complexity or imaging problem. And on the German side, similarly, there was now a new initiative covering all 36 university hospitals who together within a couple of months set up a new initiative that we must be a network. We must act like a network and not pool the data centrally, but the data will stay locally and the algorithms will travel to all those nodes. And well, there's a data set now of 14,000 examinations, and we can push the newest algorithm versions to all those sites, and they can use it similarly or synchronously on their data. That's a bit the idea. And of course, programming-wise, we have multiple levels, and we need them. We need to configure our new ideas and make them available first, and then to test them on retrospective data, and then to qualify them like a medical product with all sorts of quality control measures for prospective clinical validation and later for clinical use. So just another example that came out of that. So we have tools where the image registration is just an important step. As you saw here on the left side, you can register inhale and exhale data very precisely. And we can apply these algorithms to see what is the change over time in a cancer, in a chemotherapy patient. And so this is a 6 months follow-up case from Nijmegen, and all the blue dots that you see on the right side is what the computer assessed as a change, as a potentially relevant change. And I believe strongly, even though immunotherapy is complex, and of course tumors can initially grow and then the therapy can still be successful. But I think if we do it right, then together we can be faster, we can say earlier than the current standard of clinical care, whether therapy is successful or not. And this is a complex question. It's not only about size. So just let me have a look for the last minute what we are doing at our institute, just because we only deliver some pieces, and other groups, like in Amsterdam, are doing additional pieces. And I think if we work together, we can go pretty far. So we work in diagnostics to measure the right informations to make the imaging even better, or on these wealth of pathological data to derive patterns even from small data sets, which can be predictive in a robust fashion, or make minimal invasive interventions more safe, that then they can be applied more broadly. And of course, what I told you before, the tumor follow-up must be, in my view, more precise earlier to decide whether or not the therapy shall be continued. And together we shall collaborate to bring, in the end, clinical decision support to the next level and to help to deal with the complexity or to help to resolve them. So if we do right, we have an impact in multiple directions of society, not only on the quality and precision of clinical decisions, but it will not stop before the patients. They will also know about these developments and tools, and probably this patient involvement, this improving the dialogue between the system, the medical system, and and the patient will also be impacted by these tools. And I believe there's a new generation of medical doctors coming, and they will probably learn early on the question, what is the limits of our knowledge, and how can we use computers best to help us? So I believe, as I said before, the question whether humans are replaced is totally off, because we will just reach the next levels with these tools. And we need people, everybody who is ready to help to make medicine better is needed. And it's really like navigating in an uncertain territory with a lot of options. And we need to decide about the right directions. And there will be small steps and a bit larger steps. It's not like a big revolution, but there will be several achievements which then grow together to build, well, what we call the digital medicine of the future. And I'm thankful to all the people that I was able to work with at Fraunhofer Mewis, and also, of course, in collaboration with the great teams in the Netherlands. And I'm really looking forward to what we can do together to achieve these goals of precision and reducing side effects. Thank you so much.
Thank you very much for this wonderful talk. It's inspiring, but also clearly raises a lot of questions about the future. The first question, when you talked about reducing complexity and the human brain can only sort of process 4 or 5 variables, how do we make sure that all these tools are actually explainable, that our human brains can actually follow the algorithms in their findings and decision support systems, that we actually dare to follow the advice?
Thank you. I believe we already see steps in this direction, and it will never be perfect. So like we never perfectly understand our fellow humans, but we will be able to trust them. And how do we do that? So the first step, in my view, and we invest quite a lot in this direction, is that the systems are really able to tell you how certain or uncertain they are. So if you have a new case, where it could be that it was just not represented in your training database. It's just unacceptable that this new case, which is very different from all the algorithm has seen before, that the system just says, well, 70% just by extrapolation, that's the closest I have. It must say, I don't know. And so the ability of an AI system to tell you, I don't know, is very important. So that's the first step. And so obvious errors are detrimental to the trust that humans would have. And so we must go from different sides. And the other thing would be that we can ask the system, well, show me the most similar cases you have seen and which might be similar and what was the outcome. So these similar patient display. There's also another type of question where you can ask the system, what was most indicative in the data for you to arrive at that conclusion? And that could be displayed. So these are just three different sides that we are currently working on, not we alone, worldwide, the community is working on. And there are more, but these modules of explainability help to create a trustful or a trustworthy system.
One of the things that is related to trust also is we should learn from our past performance. We should learn from our past errors and also our successes. So what are your main lessons from the past of applying AI for fighting against cancer?
Well, probably there's many, and I'm not sure which one I should pick, but what was striking to me is how much, or often, I don't want to say for all of you who are medical doctors here and listen, but regularly I felt that medical doctors are in a way overwhelmed with that story of AI because it's kind of hard to understand what it really is. And then they have an imagination, oh, that could do that or that and maybe even be better than me, which might be true in a specific task. But then what we did is to do a hands-on workshop where we did this 3 times with young radiologists in this case, and we invited them for 2 days and even brought them to a programming level. Several of them have never touched a source code before, but we did in Python and with Keras and all these libraries. And then we let them change the source code and see what is the outcome. And then, of course, we talked about the theory and about some applications and about data curation, but also on this programming level. And I believe to have observed that there was like a change, a really strong change in their embracingness of these methods and their ability to judge what it really is. It was like a demystification. And I think this is what we need. We need to grow together as a community from multiple disciplines. And we cannot live in a mystified situation anymore. So we need to get a common ground. So that's my main answer.
Thanks.
Thanks again, Horst, for your wonderful talk. In the interest of time, we have to move on. And with that, I would like to introduce our next keynote speaker. It's a great pleasure to introduce Dr. Vitseman. He's a dedicated breast and interventional radiologist at the Radboud MC, as well as at the Netherlands Cancer Institute. He's an expert in breast imaging with a particular focus on breast MRI, and is a scientific leader of the clinical breast research group at Radboud MC that aims at clinical validation of novel strategies for breast cancer detection and treatment. While most doctors still have difficulties to understand AI, grasp its potential, Dr. Vitseman is a very nice example of a doctor that actually understands both the clinical as technical domain very well, and I'm very much looking forward to his talk. Dear Vitse, the floor is yours.
Thanks a lot. I'm going to talk to you about a case of breast cancer due to the simple fact that the clinical potential of AI for oncology is simply way too big to actually cover completely in a talk of 15 minutes. So we dive into breast cancer, and as Jan Jacob just said, I'm a breast radiologist, so you will see a lot of images. Honestly, I need to always state it. I work with a lot of companies to actually make things better, and that's sort of important. But for the most patients, it doesn't really matter. What does matter is that they come into the hospital at some point in time. And while a number of our patients actually come into the hospital because they had complaints, many come because there's a regular scheduling of something or because they are just scared. That means also that many patients that actually enter the hospital do not at all have breast cancer. They have something different, they need some comforting, and then they go home. There's a small group of patients that actually does have breast cancer that goes through and that enters in the middle and enters at multidisciplinary team meetings where AI will likely and eventually play a big role. Honestly, at this point in time, it doesn't really. One of the things that you could do with AI would be simply patient routing. This is actually a very simple logistic regression model that uses or that calculates breast cancer development risk for patients based upon hormonal and genetic factors and so on. Obviously, you can take this and then combine that with, in this case, mammograms and a bit of AI. And what you get to see is that, well, none of these models predicts risk on breast cancer very well. If you look at the ROC curves, they're all horribly low. But the classic model, the classic familial risk group model, is the yellow line at the bottom. And then if you look at only the images and a bit of AI, you go to the green line. If you combine everything, you get to the red line. So what you get here is already sort of an integrative approach to, in this case, risk, asking ourselves which patients to actually enter the hospital. Now we go to radiology, and radiology over the years has changed quite a bit. As Horst deservedly said, we see a lot more images nowadays than we used to. Actually, there was quite recently a publication in the NTVG where they actually said in the last couple of years the workload of radiologists increased by about 600%. With that and with all these similar images, we do a lot of repetitive things. So we are looking at the same images all the time. And it would be easy to ask a computer to do that for us. And actually AI, or at least machine learning, is not that new in this field. Screening for breast cancer has been done for a very long time, and machine learning actually dates from the 1950s. However, for computers it's not that good. It took almost 50 years to come to a level where there was an FDA approval, and those studies basically said subsequently, look, the AI can actually find this and find this and find this, and these sort of stupid radiologists missed half of these cases. Next question is it really useful? Because in the end, the radiologists definitely missed half of the cases, but unfortunately, the AI missed the other half. And this is basically what it led to. What you see is that radiologists only started looking at those cases that were flagged by the AI, and then also subsequently said, okay, I find this one relevant and that one not. And consequently, the netto effect was that the screening performance decreased by the use of AI. So there's sort of a risk in this kind of approaches, right? And the question is, how can we prevent this, and how can we actually get a little bit better with something like this? I guess this is for me the paradigm shift in AI, where we move from the classic machine learning approach to deep learning. Originally we told the computer, if you see a star, it's cancer. If you see a small round mass, it's no cancer. Nowadays you tell the computer, these are yeses, these are nos, and you give the computer a new form and asks, what is this? Obviously, the computer can only say yes or no in this case, because you need to change the labels to get to another answer. But now it will say yes or no. And in this case, I tend to think it will say yes. So we'll put a needle in this small star. Overall, the applications of this approach in radiology are massive. There is sort of image generation, tissue segmentation, lesion detection, classification, and also therapy selection and response prediction. I'll run over these in the next couple of minutes, just to show you how far we are, and to show that despite the fact that Horst just said it was, or this is really a disruptive technology, these processes are horribly slow. Let's start with image generation. This is an MR image, and this is case space. So what you see here on the upper level is case space, and on the lower level the reconstructed MR image, and you see that the center part of case space gives you the contrast, the outer part of case space gives you the fine details, and if you have everything, you get nice images. However, we do not normally acquire these kind of images, but we acquire something like this. This is Jonas's work here next to me. If you take just a few lines of that case space and you reconstruct it in a physical way with nice formulas, you get the contrast sensing image. But if you take the deep learning approach, in milliseconds you have a very nice image. This is also work from Tao Tan in Nijmegen, and what he was doing was actually creating a 3D ultrasound image where the ribs and the thoracic wall are actually removed, because those would look black. And there is an AI algorithm in this image, but it's actually not very good. However, as a radiologist, you can just look at all the black spots that are still there. That might be the real cancers, and you just look at those and you are way quicker and you feel much more confident that you really have seen everything with an AI that actually does not perform that well. If you then go on to lesion detection and classification, it becomes a bit trickier. This is screening reality, right? A mammogram there, that's the MR that comes with it. And the question is, do you see that lesion in that mammogram? Honestly, I don't. And this happens all the time. But AI nowadays is actually at a level of a breast radiologist, if not better. These are different commercial algorithms actually that have been tested against a bunch of radiologists. And what you see on the left is that the AI, the top-notch line, is so much better than all the radiologists below that even when they use the AI, they do not get to the level of the AI. I'll show you that in a bit. The other shows you the British situation, where the AI is definitely better than one radiologist, but not as good as two radiologists in consensus. So there's still a little bit to gain, because in the end it should be capable of getting there. The question is, can we use that better performance of AI, very different from the original CAT, to our advantage? And that starts with the classic reader studies, where you read cases with and without AI, and then what you get to see is this. You have an ROC curve with AI, without AI that improves a little bit with AI. And honestly, I think the netto effect of this in clinical practice is next to nothing. Either the cases have cancer, and then it's easy, or the cases don't have cancer, then it's easy as well. And only in the very small gray area in the middle, the AI might actually make a very small difference. You see the same here with this ultrasound AI. It works for the non-experienced radiologists, they all get a little bit better, and for the experienced, honestly, they really don't look at the AI. So it's hard to get these things into real practice. If you see this one, I already told you this, very good AI program. If you look at the right graph, then you get to see that none of the radiologists, or actually only one, achieves the performance of the AI system by itself. So these AI systems are capable of doing something else. They can, for example, divide a batch of cases into bins that contain a number of cases with a certain risk. That's what you get to see here. There are case-based scores 1 to 10 for this mammogram AI program. And basically the normal mammograms are equally divided in those bins, but the risk of harboring cancer is higher. So this is the normal cases divided over the bins. These are the cancers divided over the bins. And basically, if we would not look at half of all the mammograms, I would only miss 5% of the cancers. With something like that, I could halve my workload without doing too much harm. And what you see is basically, the higher you put that threshold, the less work I have, and the fewer the impact also on the recall of benign lesions. And in the end, you would like to place this threshold at about 90%. Just not looking at those will actually make my life a lot easier. And if it doesn't mean that the patient gets worse, then this is where I would like to go. Obviously, these AI systems sometimes make unfortunate mistakes. This is from the Google paper. And what you get to see there is a big, somewhat irregular mass. And I don't think that there will be a single breast radiologist who misses this, but the AI system did, despite it being better than most radiologists in the study. So we need to do something useful with this kind of stuff. And one of the things that I think is very useful is actually to use it to select patients for additional tests. In this case, for example, if we would select the top 10% of risk cases, and we would put those, for example, in the MR, then we would prevent about 50% of all interval cancers in screening. If we would bring those back into the hospital, we will start classification, and then we will see these kind of lesions that I would not think are cancers in practice, but AI actually tells different, and basically the middle one is a cancer, and I would not have guessed that. But we'll put a needle in due to the simple fact that there's a second pair of eyes that tells me differently. And this is what you see in a commercial version of that, a strange lesion, and there are actually a couple of physicians that rate that really low and might not even do a biopsy, but using the AI system, they will all biopsy the lesion and thus prevent this cancer from going unnoticed. There's actually also a lot of information in text. This is work where we actually looked at radiology reports, but you can also do that on clinical notes, for example, and then separate invasive from non-invasive cancers just on the words in the report, not on looking at the images at all. There's a lot of information out there that does not reach the conclusion in the end. If you look at breast MR, as Jacob said, sort of my hobby, you have two cancers here, a big one in the right breast and a very small one in the lower corner of the left breast. And you need to classify those as being malignant. The AI systems that are currently around have a performance that's definitely better than the classic machine learning systems. Those are the yellow and the blue lines. The CNN is the green line, but the radiology is what's the red line. We are not really at the level where AI can replace radiologists here. However, what we can do is, if we have called it a suspicious lesion, ask the computer, do we really need to poke a needle into this patient? And this basically says, well, in 40% of cases, you can just ignore it, and it works. We can also try to incorporate that. This is a very new project that we have. It's no longer confidential. We got the grant. But it's a very new project where we actually intend to build AI into the scanner and actually have the machine tell us whether or not it's needed to scan a full protocol to actually figure out what the lesion is. Then we get to the next thing. If there is a lesion and it is cancer, we obviously would like to know how to treat this kind of cancers, right? And cancers are not uniform. They are not uniform from patient to patient, but they're also not uniform internally. And you get to see that some of these, or the bigger cancer here on the left, is very inhomogeneous. There's a lot of necrosis in it. You will definitely treat that differently than the sort of homogeneous cancer on the right side. If you do that with classic machine learning, and that's actually most of what is out there in the literature in this point in time, you see that you already need to know quite a lot of cancer biology to make this useful. Because only the grayscale matrices don't really work very well, but if you also add molecular subtypes to it, then suddenly you get a nice evaluation and a nice response prediction out of it. And it works somehow a lot better in, for example, triple-negative cancers and luminal B cancers, but it doesn't really work in HER2 cancers, and I have no clue why. Still, you get to see that there are many features that you can get out of this, and those are in essence the features that we look at as radiologists all the time. We look at margins, we look at heterogeneity, but we can't grasp the image, and that's where it helps. It makes the image more, well, useful or at least understandable. Obviously, this goes into CNNs nowadays as well. So here's an example. Small study, 142 patients, 3-class prediction with an accuracy of 88%. This is actually a very basic CNN approach. And you get nowadays exactly the same sort of studies in pathology. So you have a pathology slide, you do exactly the same. You get the same images. You also get sort of the same performance. And obviously, what we are longing for is, sort of a combination to this. What I really like actually is the fact that with these combined approaches, we have a return to phenotypes. Honestly, biology and cancer treatment has really moved into the direction of genotyping, because in the genes is the answer. If you really know what kind of cancer you're looking at. But it's not entirely true. Actually, it's the cancer and the surrounding in which it grows that matter. And that is, in the end, what you get in the phenotyping. So combining these things actually will likely get you to a much higher level than just looking at the cancer cells itself. In the end, this is what we would aim for: integrative medicine, taking the images and the pathology and the genome, and actually also the knowledge that's in all those reports together. Bring that to a platform like this one that we are actually studying, and try to actually bring this to our clinical tumor board. make sure that all the relevant information is presented there in a fashion that's interpretable for the doctors, that actually makes simple classes that actually fit also with the therapies that we currently have. In the end, then we get to sort of a cookbook sort of therapy, but obviously the diagnostic part is the thing that really matters, because that is in the end where you decide how to end up at a certain treatment pathway. That's it. Thanks for your attention.
Thank you. Thank you for the nice talk. So you have given many examples of algorithms which can support radiologists, but you believe that at any point we will be at the situation that one of the algorithms is actually replacing the radiologist from the loop. And if so, which application do you think this would be?
Well, I think I made it quite a case for screening. I really think that is a repetitive task that is the same all the time, where you have very limited information from outside that you need to know. So the task is quite standard. And with that, I think you can get to a level where the AI is really better and actually also makes our life a lot nicer. Honestly, I didn't become a radiologist to sit and watch screening examinations all the time. It's the integrative part and the discussion with the patients and so on that makes the job fun. And I think that is a place where AI could really help, could make it more fun, and actually also better for both me and the patient. In the end, an AI program doesn't need a cup of coffee at some point in time, and I do. And that is sort of a risk.
And well, you made also clear that there are still way to go. We still need to improve. We are not there. And you show several examples where the system had some, we can say, stupid mistakes that maybe radiologists wouldn't miss. So we have to go there. Horst mentioned, like, okay, an example like how to increase trust in the medical community by asking them to join. What will be your advice for us to convince, we can say, the clinical community to join and try to help us, and we create together these solutions?
I guess that's where it starts, right? To do this together.
Yeah.
Which means that we should talk to each other from the start. Even before actually collecting the data, just having a clear picture of what are the problems, what are the potential solutions, in what direction are we going to work to actually solve this. What pieces of the puzzle are relevant to patients as well? I mean, and to what level can we, or is there a real answer to a question? Because when the answers to the question is not so clear, it's also very hard to teach a computer to do it very well. And I think that can only be solved by really working together. I also think that the Star Wars technology is sometimes not as Star Wars as it is supposed to be, whereas the medical studies are not as Stone Age, as Horst likes to call them. But at the same time, it is all about cooperation. It's really all about making a network of people rather than of just machines.
Thank you. Thanks for your answers. I will have to continue now with the part where we explain the activities in our lab. And it's also my pleasure to introduce the team. Well, the scientific directors and myself, the lab manager, are sitting here at the table. But of course, we cannot do the work without our great PhD students, Shannon, George, and AJ, who have recently joined our lab. As you can see, there are still 2 open spots. These are vacancies which are currently open. So if you're interested in joining us, please let yourself known. And I will introduce the 2 projects which actually are still open before giving the rest of the presentation to the 2 lab managers, to the 2 scientific directors. Apologies. And one of the first problems you want to consider in a lab is model and uncertainty-based multimodal segmentation for gross tumor volume. So basically, we want to segment the tumor, and one of the reasons why we think this is relevant in the lab is because many of the standard segmentation models do not actually have any prior knowledge on what the object itself should look like. So this is a result of a UNet that is segmenting the vessel tree in the liver, but as you can see, there are some blobs somewhere, and as you know, well, vessels should be continuous structures. So there is many of these models don't have this knowledge included. So another issue we would like to address is the fact that these models are supervised models, so they need some ground truth data. But there is a small issue, or a big issue with this, is that many of these problems have a large inter-rater variability. So in this case, you ask 5 radiotherapists to contour the gross tumor volume, and you'll get 5 different answers. So how do we incorporate this into the model? Another thing which is definitely very relevant is the fact that for gross tumors volume segmentation, often multiple modalities are used. Here it is an example of MRI and CT and PET-CT. And these images are acquired at a different point in time, so likely there is some misalignment between these scans. So the goal of this project is to create a model, a segmentation model, which has knowledge about what the shape of a tumor should look like. So it should be a kind of a closed surface. And on the other hand, we also want to incorporate uncertainty in these models. So not only how certain the model is, but we also want to model the inter-rater variability. A second open, more moonshot type of project is actually exploring the potential of novel AI concepts in oncology. And here I just gave one example. It's about predicting the response to a specific drug by having the gene expression data and the molecular structure of the drug. And right now, most of these models are either based on classical machine learning or very standard multi-layer perceptron. Another very relevant problem here is not so much that we want to predict the drug response of one drug, but we want to predict the synergetic response between drugs. This is typically a much harder task, and the problem space is also the problem space of 2 drug combinations is of course exceedingly large. And for that, we need to actually figure out what would be the proper computational model to do this. So right now, classical machine learning is used, or MLP, multi-layer perceptrons. But all of these leave still quite some room for improvement. So perhaps we can use graph neural networks, or even use a kind of find another geometric structure to do this. This is the Calabi-Yau manifold. Who knows if this will turn up somehow. And this is not the only question. So we don't only have the molecular structure of the drug. We don't only have the genetic data, but we also have other data such as biopsy data and things like that. So all in all, what we want to do is, well, figure out what is the best geometry for this task. How do we incorporate different modalities of data? And of course, one important problem is always, how do we figure out why a certain prediction has been made? So can we go back to the original genetic data and figure out anything about the biological origin of this problem?
In the next project, we are going to focus on outcome prediction in calcified breast lesion. And 1/4 of women with calcified lesions have a breast cancer or a precursor of cancer that is called ductal carcinoma in situ, DCIS. And luckily, DCIS, or many of the DCIS, they are indolent and they don't require any treatment, and they are not supposed any risk for the women's life. However, it's very difficult now to see which of these DCIS are indolent and which ones are not, and which women will require treatment or not. So what is happening now, it's most women with DCIS, they are under treatment by chemo or by surgery or even radiotherapy, and they suffer all the consequences that this treatment have physically and mentally. So what we want to do in this project, and Shannon will make this sure that it happens, is to join this information from radiological images and also pathological images to try to see first if we can identify DCIs faster in the screening, but also if we can, at the diagnosis time, we can really identify those ones that will require treatment and which ones won't. In the project with AA, we will focus on integrated diagnostics by combining genomic and histopathology for the treatment decisions in women's cancer. And in this project, we want to focus in the risk of recurrences. So the risk of recurrence, or an assessment, an accurate assessment of risk of recurrence, is very important to see if the patient will need systemic therapy. Now, we can say the state of the art for this is a semi-quantitative morphological assessment of carcinomas, or a slice of carcinomas. And we can see with that if the diagnosis, and we can also perform assessments about prediction, about prognosis, and also about treatment response. Molecularly based personalized assessments has been shown also to be very accurate, and in different studies has been shown to have a very added value to identify signs of prognosis or signs of progression to the diseases. What we want to do, or EJ will do in this project, will focus on integrating all this information together with clinical information of the patient using AI to try to improve this risk of recurrence in women.
So last but not least of our projects, number 5, although we're still looking for funding to expand the lab for more projects, is about active MR acquisition and real-time tracking of tumors and organs at risk during MR-guided radiotherapy using AI. To understand this project, first a slight introduction. Radiation kills tumors by damaging DNA, but also can damage normal tissues surrounding it, and we use complex dose distributions to spare normal tissue as best as we can. Primarily due to anatomical changes during treatment, as indicated by these two images of an inhale and exhale lung, it's challenging to deliver those precise dose distributions very accurately. To that end, the latest kid on the block in terms of radiotherapy image-guided machines is an integrated MR-Linac. So it has radiation delivery device as well as the ability to make MRI images. And much helped by the introduction, as Vitseman did in his keynote, normal MRI images take a long time, but we can accelerate them by different patterns in K-space, which reflect the different spatial frequencies. And it has been shown already that AI algorithms can better reconstruct images from undersampled K-space data than classical algorithms. What we want to do in this project is not to reconstruct these images, but learn the differences in motion and the variations of organs and tumors directly from K-space, skipping the reconstruction step, as well as learning the optimal real-time active acquisition, such that the AI can guide the MR machine to take the optimal measurements based on previous measurements as well as the predicted motion. Link those motions to changes in radiation therapy beams and validate the performance on the devices that we have at our disposal. So that wraps up in a nutshell what we have designed for the lab as far as we have budget so far. As I said, we're looking for further funding to expand. Before we continue to the formal opening of the lab, we first have a final video recorded by Professor Dr. Geert ten Dam. She's the president of the executive board and professor of educational sciences of the University of Amsterdam.
Good afternoon, everyone. Congratulations. This is a very important step and a wonderful example of the collaboration on AI in Amsterdam, in this particular case between the Netherlands Cancer Institute and the University of Amsterdam. The Netherlands Cancer Institute has been a part of the Amsterdam Coalition AI Technology for People since day one, and we are really happy to launch this new lab together. The broad Cooperation with other institutes, public partners, hospitals, and of course also the business community is essential, we think, because AI is not merely technical, is not only machine learning, but needs to be applied and human aspects should be incorporated. Well, the new lab is special and important as the digital revolution in healthcare is allowing us to make predictions in diagnosis, prognosis, prevention, and so on. And the new AI Oncology Lab melds expertises from both the NKI and the UVA together under the leadership of Clarissa Sanchez-Gutierrez, who was appointed Professor of AI and Health at the UVA last year. We are so happy you have joined us, Clarissa. Your interfaculty research group, bridging Amsterdam UMC, the medical hospital, and the science faculty will help to develop, validate, and put into clinical use socially responsible AI solutions. So we are looking forward to a fruitful collaboration and to seeing the results as they begin to flow from the lab. Again, congratulations.
Thank you very much. As you can see, the table has been expanded by two esteemed guests. Professor René Medema, Chairman of the Board of Directors and Director of Research at the Netherlands Cancer Institute, as well as Professor Alfons Hoekstra, Director of the Informatics Institute and Professor of Computational Science and Engineering. So I give the floor to you to do the formal opening and looking forward to this beautiful bottle.
Okay, yes, well, thank you, Jan Jacob. But before I open this bottle, I just want to express how delighted I am that today has come. I'm very pleased with the fact that we've been able to establish this access so that we can tap into the great expertise that's present at the UVA in artificial intelligence. And I think this team effort can deliver great results. And you've been talking to this point already, so maybe I will stop there and do the honors, I guess. So I was asked not to ruin any of the studio lights, so we'll do that. Ooh, there's a lot of pressure behind it. There we go. Ooh.
And while the glasses are being filled, allow me to also on behalf of the university and the Institute for Informatics to congratulate you, and I'm very forward and very much looking forward to the collaboration, the opportunities offered by this fantastic collaboration, and I'm sure this is going to be a fantastic success.
Let's cheers to that.
Cheers.
Congratulations.
Congratulations.
Finally started.